Uh, Good afternoon, everyone. Really nice to be here. And I'm Sioban Keel. I'm one of the hematologists at the university and also at the Fred Hutch. And I see folks in general hematology clinic where I see acquired disorders like aplastic anemia and PNH. But I also run a program that sees inherited disorders. And so I have a monthly clinic where we see folks that have inherited reasons that they develop leukemia or aplastic anemia presentations. And we see folks along with a genetic counselor and also a geneticist. And so today, I just want to emphasize that for most people here, this isn't particularly relevant. I'm talking about syndromes that are inherited Mendelian syndromes, if you kind of remember Mendel and his P's, that inform a risk of developing cancers. And so these are broadly, this is kind of a complicated slide, and it's not meant to have you guys know all of these, but these are variably classified into what are called the classical inherited marrow failure syndromes. And you may have heard of some of these diagnoses. They oftentimes present in children at very young ages, but we also diagnose these in adults. Diamond-Blackfan anemia or Fanconi anemia are examples. There can also be folks that have inherited reasons that they develop blood cancers, including MDS, where they don't have any real presentation before the development of their MDS. They don't have low blood counts before they come to presentation with their MDS. And then there are also folks that we now recognize may have kind of long-standing mild changes in their blood counts. And some of those individuals subsequently develop MDS. And we realized, those low blood counts they had for their whole life were related to an inherited cause. And then lastly, I'll just outline that there are a number of disorders that classically in medicine, we thought of really in silos as being cancer predisposition, that these were individuals and families that just got breast cancer or they just got ovarian cancer. And you might kind of remember that BRCA1 and BRCA2, Angelina Jolie, or there have been a few other celebrities that have come forth with inherited reasons that they developed cancer. And what we're now appreciating is that those families, their cancer spectrum, the types of cancers we see in those families really aren't just restricted to breast or ovarian cancer, that in the families that have BRCA1 or BRCA2, there can be breast cancer, there can be ovarian cancer, and there can also be blood cancers, MDS or leukemias. Um, so, hold on, guys. I already screwed this up. Okay, there we go. So I'm going to step back, and you guys have heard a lot about the words mutations and genetics, and I just want to make sure we're all on the same page. So when I talk about genetic information in the cell, what are we talking about when we say the genetics of the cell? Well, I'm talking about the instructions that are contained within the individual cell that tell that cell how to behave, how to go through its life. And that genetic information, if that cell divides, let's say you have a stem cell in your bone marrow and it makes your white cells and your red cells and your platelets, it has to make a copy of that genetic information to pass on to the next cell. Or the other setting where you sometimes think about this is in the egg or in the sperm, that genetic information has to go to the next generation. And so how is that genetic information held in a cell? Well, it's on your chromosomes. And if you kind of remember, most of your cells have 23 pairs of chromosomes, and you get those chromosomes half from one parent and half from the other parent. Your germline cells, the eggs and your eggs or sperm, those contain half that amount of chromosomes rather than 23 pairs, just 23 chromosomes. And the chromosomes are these long strings of DNA. That DNA might be wrapped around a bunch of proteins so that it can fit in the tiny space of a cell. And the genes themselves are composed of base pairs. And so those base pairs are, think of them as the ABCs of how a gene tells the cell to do this or to do that. And so I just have a tendency to press that one. So anytime there's a change in that genetic information, that's called a mutation, you guys. And so what I'm showing here is the change in the ABCs of a gene that might be normally coded as a T or a G, a T that goes to a G, when the reference genome, what the majority of people have, is a T to an A. And those genetic changes can be kind of a few things. They can be a genetic change that's disadvantageous to the cell, that it can lead to a cancer. But we can also get genetic changes in our cells that are advantageous, that the cell does a better job at its job than before it had the mutation. Or we can get changes that don't mean anything. We're always acquiring as we age. And you heard about that a little bit earlier when we talked about CHIP, or these mutations that are present in people that don't have changes in their blood counts or only have minor changes in the blood counts. And that's because, unfortunately, all of us, as we age, myself included, we're acquiring genetic changes in our cells that rapidly divide and in our stem cells. And so here's just an example of whether you're a cat lover or a rat lover, whether this is an advantageous genetic change or not. So I have a cat, and the C gets changed to a rat, and you can see that that has a dramatically different result. You got a rat there. So the other piece that's important to take into consideration when you think about mutations is, where is that mutation occurring? And so we talk about, and that's what we've talked about today predominantly, what are called acquired mutations. And the other term you might hear, and so I'm just dropping it so you've heard, is acquired mutations are also sometimes called somatic mutations. And those are changes that occur in the cancer. And so the example that I'm showing here is, let's say this individual has a lung cancer. The genetic change in that lung cancer is indicated here as yellow. That change can't be passed on to this person's child because it's a genetic change that's restricted to the lung tissue. It's not in the sperm or it's not in the egg. As opposed to an inherited mutation, the other word that we use to call an inherited mutation is a germline mutation. And those are changes that occur in the egg or sperm in an individual. And so when that individual has a child, that genetic change then, because the child starts from a single-celled organism, divides into a person, that genetic change is present in all of the cells of the person. So you guys, I just want to make sure we kind of are following that. So you can have acquired mutations that are just restricted to the cancer tissue, or you can have a germline change that then would be passed on and present in all the tissues of the little one. So in aplastic anemia and MDS, this can pose a little bit of trouble, challenge to us clinically in trying to distinguish between an acquired mutation or an inherited mutation, because classically, the tissue that we test for this is we test the blood, right? And if you have MDS in your blood, you have changes that are acquired changes in the cancer, but you're also carrying along the inherited changes. And so if we just look at your blood, we can't tell, is that change a change that was in your MDS, or might that change have been in the cancer itself? Excuse me, an inherited change. Though we get a little bit of hints when we say, gosh, how many of the cells look like they contain that change? So to get around that, what we do is we can test something else. We can test a skin biopsy, for example. So here's, just to hammer that point, here's one study that looked at a group of patients, a large group of patients that had had genetic testing, that had molecular profiling of their blood cancers. And it asked, how often were those changes that were seen actually inherited changes that were contributing to the person's development of cancer? And at least in this study, it was around 12%. And the genes that were inherited changes in the genes are listed there. And I'll come back to that DDX41. That's the most common inherited risk for developing MDS that we currently recognize. And so, again, the way that we can get around this, if we're having trouble distinguishing, is that genetic change in the cancer, or is that genetic change an inherited change? We just test something that doesn't have the cancer. So rather than testing the blood, you draw a skin biopsy and say, well, let's sequence the skin biopsy. That doesn't have the MDS. So if we see the genetic change there, you can say that must be an inherited change. So why do we care about identifying these inherited syndromes anyways? You know, what's the clinical relevance to that? And I would say first, you guys, this is a field that's developing. It's kind of developed over, I would say, about the last 10 years. And we are in its beginning. So we're sorting out, where exactly is this most relevant? And I think probably the lowest hanging fruit that most folks agree is that if a person is going to a transplant and you're going to use a sibling donor, that if the person had an inherited disorder, you would like to, if possible, it's not always possible, sometimes you have to choose the best you can get, but if it's feasible, not to select a donor, a sibling, that might have the same genetic predisposition to developing cancer. The other settings where it's helpful for us in terms of why it impacts care is sometimes these patients can have problems that are unrelated to the bone marrow. These are genetic changes in all their cells. So they might be at risk for developing lung disease. They might be at risk for developing liver disease. And that's important to know for surveillance, that we monitor people for these complications. And it's also important if they are going to a transplant, that it helps us to think about what sort of preparatory regimen, what chemotherapy or radiation should they receive before they get a transplant. Because if someone has an underlying lung problem or liver problem, they can have a lot more toxicities with standard approaches to transplant. It obviously can have implications for family members. It can inform how they make decisions about family planning. And we're beginning, I would say the slide really should be revised. Initially it was a hope, but I think we now have a few examples where recognition of these disorders actually informs care. So these are just, again, to kind of hammer the point of why we can care about these syndromes. Before, these were widely recognized. In studies where we looked back at our experience, we've found that there have been cases where we didn't know any better. Medicine advances and we know things now that we didn't know 10 years ago. And so these are just some examples of looking back and saying, gosh, some of those individuals that developed what's called a donor-derived leukemia, they were transplanted and then got a leukemia from the donor cells, that some of those donors actually harbored inherited reasons that would have predisposed the person to developing that cancer. So these are now pretty well recognized in lots of national and international classification systems for our blood cancer. These are just two examples, the World Health Organization classifications of our myeloid malignancies and another classification system. And we're also now incorporating these in lots of the national guidelines that help physicians like myself to make decisions around how to treat patients. And so here are just two examples, the NCCN guidelines for MDS and the ELN guidelines for AML. So to give you a sense, you might say, well, gosh, Dr. Keel, you started this by saying these are uncommon. And I think that is the take-home message. The majority of patients we don't think have one of these syndromes that we can identify. But I put this in just to say, well, what is kind of the rough estimates of the incidence of an underlying inherited cause for developing, let's say, MDS? So this was a study that took MDS patients across a broad age spectrum. So pediatric MDS to the more common presentation of MDS, older people. And it sequenced them for underlying inherited risks. And across the disease, or excuse me, across the age spectrum, what was found was about 7% of the individuals harbored an underlying reason that they developed cancer. And you guys, that's pretty comparable to other solid tumor cancers where we very routinely recognize the risk of inherited causes. So you're probably all aware of the families that have breast or ovarian cancer. And if you looked, what's the incidence of a germline mutation in breast and ovarian cancer or individuals, it lands around someplace around 10%. So I think what we're learning is that blood cancers aren't that much different than our solid tumor counterparts. There are these underlying inherited disorders. And what's kind of interesting, this is a little bit of a funny thing to look at, but when you look at this graph, what it's showing is the age at diagnosis. It kind of reflects what types of changes, genetic changes, contribute to the cancer. So that if you look at individuals that develop their MDS in younger ages, the genetic changes that led to their cancers are mutations in those inherited bone marrow failure syndromes, Fanconi anemia, DBA. And if you look on kind of a more common presentation of MDS in people who are older, it's kind of a little bit broader spectrum of different genes that are affected, including this most common one, DDX41. So DDX41 are the most common germline mutations predisposing to MDS. They're reported in all comers that have MDS. About 2 to maybe 6% of individuals harbor one of these underlying mutations in DDX41. And what I'd say is interesting about this cancer predisposition syndrome is I think we oftentimes think that, oh, if this individual had an inherited reason for developing cancer, they would have presented with their cancer at a young age. They would have presented as a pediatric patient. And this is an example to us in medicine, a reminder that genetics can inform what happens to adults too. So the presentation of patients that have inherited DDX41 mutations, they present with their MDS at the same age as people who develop MDS that don't harbor an underlying inherited reason. They present kind of in their 60s also. These individuals may or may not have a history of prior low blood counts. There's a question of whether the full spectrum of other cancers that DDX41 patients develop. There have been MDS and there have also been some other forms of blood cancers. And I'll just say that oftentimes, for many reasons, patients lack a family history of MDS. And that's one, because oftentimes families can be small, so there aren't a lot of individuals in families, so we don't always recognize by a family history. And that's because not everybody, when we talk about having an inherited cancer risk, the word is risk. Not everybody that carries one of these genetic changes in a family ends up having the cancer. There's different penetrance or the frequency of who gets cancer and who doesn't. So how do we approach it? I would say first, we're real thoughtful about getting a focused medical history and physical exam. We look for any other findings on physical exam that might suggest one of these inherited disorders. I think having prior CBC data can be really helpful if you can look back and say, gosh, this person had low blood counts for a long time that were never explained. That sometimes can be a hint to an underlying disorder. But I think what's important, we and groups at other centers have done studies to ask, can you rely just on a family history and a physical exam? And I think the bottom line is that can suggest the possibility of an inherited disorder, but the absence of a family history of cancer or the absence of physical exam findings, that doesn't exclude a possibility of an underlying inherited disorder. So I just wanted to show a little bit about these classical inherited bone marrow failure syndromes. Again, these are rare disorders, DBA, dyskeratosis congenita, and Fanconi. And what's shown here is data from the NIH that looked in their large cohort of patients about the cumulative incidence of MDS development in these patients. And you can see it's kind of variable. It depends. The underlying genetics depends or informs that risk. Individuals that have Fanconi anemia have a much higher risk in their lifetime of developing MDS than, say, a patient who has DBA. So one of the things we're thoughtful about is, well, gosh, when a person presents, let's say with aplastic anemia specifically, with a marrow that looks empty, a marrow that has a hypocellular marrow or a marrow that's empty, is there any clues diagnostically to the sophisticated tests that we send on your blood and your bone marrow that might help us to distinguish, does this person that looks like they have aplastic anemia have an inherited disorder? And there's kind of two things that have emerged in the diagnostics that are helpful, you guys. One is the presence of this thing called a PNH clone. And I'm going to let Dr. Scott kind of go through PNH in a bit more detail so you understand what that is. But think of it as a population of cells, and those cells grow when the immune system is dysregulated. And it turns out that those are present in about 50% of people that have acquired aplastic anemia. And a number of groups now have looked at really sensitive ways to pick up these PNH cells. If you have a PNH clone, how good is that in telling you you probably don't have an inherited underlying reason for your acquired aplastic anemia? And it turns out that's pretty good. The presence of a PNH clone has is quite good at excluding an underlying inherited cause. So that can be helpful. And then the second thing, again, this is one of the sophisticated tests we send on bone marrows. We can look for a particular change using a certain way that we look at the chromosomes. It's called a chromosomal array. And again, this is helpful in distinguishing an inherited cause for aplastic anemia versus one of these inherited syndromes. And if we find this thing called a 6p copy neutral loss of heterozygosity. Think of it as just a signature on the way we look at the chromosomes. It's not present in that many, but if it is present, that really excludes an underlying inherited cause. So when do we consider these inherited syndromes? We're thoughtful sometimes. There are exceptions to all of this in folks that present with aplastic anemia that is non-severe more commonly, that the blood counts aren't as low as patients presenting with severe disease. If a person has a family history or physical exam findings, that can be helpful. History of abnormal blood counts or large red cells for a lifetime. And then the last one that I'll just highlight that we're very thoughtful about, if you look in people who present at younger age for their MDS, and you look at the signature of their MDS, if that's marked by a chromosome 7 abnormality or a trisomy 8, those are chromosome changes on the bone marrow, that's very suggestive of an underlying inherited disorder. And we always look at those patients a lot more closely. So at our center, this is kind of a broad approach of who we think about sending. It's not meant to be all inclusive. I don't think that everyone on this list has to have testing, but this is kind of broadly what we programmatically are thinking about. If we have patients that present at younger ages for AML or MDS, we're thoughtful about this. Obviously, if they have a family history that is suggestive of a genetic predisposition syndrome, there is a subset of patients that are diagnosed with something called hypoplastic MDS, you guys. That's not the majority of MDS. That's about 10% of patients. Those patients, that's an atypical presentation, and we oftentimes think about the possibility of an inherited disorder there. We think about it in our newly diagnosed aplastic anemia patients who lack that P&H clone and that 6p copy neutral loss of heterozygosity. Obviously, if they're in a family where you know they have a genetic disorder, we're thoughtful about that. And then the other one that us and other centers have done studies on is if you take an individual who has a blood cancer and a history of another cancer, excluding a skin cancer that's related to sun exposure, those individuals also are enriched for having underlying inherited disorders. So if one person has multiple cancers, we're thoughtful about these disorders. So again, this is just kind of how we're doing it here, you guys. We have partners over at the Seattle Children's Clinic that see pediatric patients, and they oftentimes transition patients over to us on the adult side. That's our team on the adult side. We're really hopefully trying to be well integrated with our broader AML and leukemia program. And in our clinic, when families initially are seen, they're seen by myself, a genetic counselor, and also a geneticist. And the services we offer in the clinic is hematologic cancer risk assessment and genetic testing. We work closely with our partners on the transplant side if that inherited reason informs their transplant planning. We think about surveillance cares for other complications related to their disorders. We do a lot of family counseling. We work closely with our reproductive medicine service colleagues. And this is also an evolving field. And so we really are trying to partner with basic science folks and clinical science folks to try and do this better. I'll just put in a big part of this when we think about inherited causes for why people develop cancer is genetic counseling. And I think there are lots of opportunities in a person's care journey to introduce this. There's a lot of pre-test counseling that we try and explain things well to patients before we send the testing, because sometimes there is information that we can know that is helpful in informing treatment decisions. Sometimes there's information we can know that really is a person's curious about the answer to something, but it might not inform their treatment decision. And I think that requires people to think deeply about it. Is that information going to be helpful for me? Will that information be cause a lot of anxiety within my family? And so I think the genetic counseling component is pretty important. And then the other piece I would just say here is really the goal of genetic counseling is to help patients make the right decisions for themselves and for their families. And then if indeed we find something and they decide to proceed with their testing, to provide longitudinal support and education. And we have lots of families that we see and they may say, we're not really thinking about that right now. And we may or may not hear from them down the line where another person in the family might develop cancer and they come back and say, this is something we want to think more deeply about. So I'd say there's lots of challenges in our field. We're still learning. I think one thing to recognize that I didn't appreciate until I started doing genetics more is we don't know everything about genetic change, you guys. There's lots of differences between you and me in our genetics. And some of those genetic changes make you, you, and they make me, me. And some of those genetic changes might contribute to the development of disease in a person. And so we're not perfect when we sequence a gene in always knowing, is this genetic change meaningful or not? Does this contribute to disease in a person? And some of you may have had this on your genetic testing, that we can get results back that are called variants of uncertain significance, or VUS. And that's a change where we don't know what it means. We have sequenced broad populations. We haven't seen that genetic change, but we haven't done functional studies to know if it's meaningful or not. And then I'd say another big challenge that we're taking on kind of stepwise is when we do find things, what's the optimal treatment and surveillance strategies for patients and families? And then I'm always thoughtful about what's the big goal here. And I think the big goal really is to try and keep people healthy and to optimize therapy. So I'll stop there and take any questions.
Nicely done. Any questions for Dr. Keel? I'll ask a question, which I think you kind of alluded to. Let's say you're a patient and you've got a strong family history and you're tested and there's nothing that comes up that says, okay, this is an inherited. As you learn more about these diseases, can that change over time?
Yeah, I think it can. And so it doesn't commonly happen, you guys. I would say there's kind of two settings. One is the setting of you had genetic testing and it's totally negative, that we didn't find anything. The reason genetic testing can come back negative is a few things. Most genetic testing we do on people is what's called targeted capture right now. That's the methodology of how we do genetic testing. And so think of that as we have a list of genes and we are sequencing those genes. So we're saying, do you have a mutation in this, 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 or this? And they can be very long lists of genes. Some of these panels are 400 genes long. So it could come back negative because we just didn't know what gene is causing cancer in everybody. There are new genes that can be discovered. And then there also are little more nuances to how the sequencing is done that potentially that testing could have missed a change in the gene that was on the panel. So the testing's not perfect. We don't know everything. And then the other thing I would say is that type of testing doesn't look at your whole genome. And so there can be families where the genetic change is a little sneakier. It's hard to find. And so the methodology can kind of vary in terms of that. And then the second is you might get a test back that has one of these variants of uncertain significance, where with current meta or kind of science, we don't know, is that a change that contributes to disease in a person? The vast majority of you guys, the vast majority, when we know more, we say, you know what, those are benign. They're not causing any problems. But rarely they can be reclassified in the future and say, you know what, that change that we didn't know about, somebody studied this further and we actually do think it's meaningful. But again, I want to emphasize, because I'm sure some of you have had testing that may show VUSs. Most of the time, the vast majority of the time, as we know more, those are classified as, don't worry about them, they're not contributing to disease.
Okay, and I'll ask another question. If you're a patient and you've had mutational testing done for your disease, do you know that you've actually been tested for mutations that have to deal with inherited disorders?
I would say most of the time, probably not, Bart. And so most of the testing, so for example, when you come to our center and you get a bone marrow biopsy, there's a whole list of things that happen to your bone marrow biopsy. One of them is genetic testing that's predominantly designed to pick up prognostic changes that you've already heard about that predict what's going to happen to your cancer. And not all of those panels include the inherited genes on it or the regions of the genes that are changed in inherited disorders.
So I'll just make a plug for you. It's important to keep in mind, to have discussion with your doctor. If you're concerned that you may have an inherited disorder, you have a strong family positive history, that the referrals need to be made so that you see the appropriate person, because not all mutational testing is the same, and you may not have been tested appropriately for an inherited familial disorder. So we're good to have experts like you.
Thanks, everyone.